Good afternoon, respected dignitaries and delegates. I am Dr. Fatima Sidiqui, and I am the lab head of Pathkind Labs, Lucknow. And very briefly, I would like to talk on the topic for today, that is the molecular diagnostics in terms of fetal genetic testing. So, due to constraints of time, I would like to jump in with a case discussion. So, our first case or our only case deals with a 29-year-old female who, by standards, is not an elderly woman who presented with a first trimester screening test or a double marker that was high risk for trisomy 13 and 18. So, following the high risk screen in the first trimester, an NIPS was advised to the patient, and we saw that it was high risk for chromosome 13 trisomy. For this, of course, the patient was then referred for post-test counseling, which of course revealed that the patient had a previous normal female child who was alive. But however, there was a previous pregnancy which was terminated because of trisomy 13 that was detected incidentally also. So there were two pregnancies in the same female showing a high risk. This pregnancy was showing high risk for trisomy 13, and a previous pregnancy was terminated due to a diagnosed trisomy 13. So this sort of, sent alarm bells in our minds. And invasive testing confirmed the presence of trisomy 13 in this fetus, of course. And due to the presence of this occurrence twice, the family and the parents were counseled for karyotyping of the couple. Couple karyotyping was performed, and we saw the following results. So the father, of course, had a normal karyogram, 46XY, but when it came to the mother, it revealed a Robertsonian translocation between chromosome 13 and 14. So, the balanced translocation that we saw in the karyogram of the mother does not really alter the amount of genetic material. So, phenotypically, the mother appeared to be normal. She also had one normal pregnancy. But due to this abnormal karyogram, there's often an abnormal segregation at the meiotic division. And she was always at a high risk for BOH, and her progeny was high risk for developing trisomy 13, which was seen in two of her pregnancies. So, of course, we went ahead and we went ahead with CMA and karyotyping. So, there's often this question of which technique is superior when it comes to this. So, CMA or karyotyping. Oftentimes, it's said that the newer technology has been more advantageous, but both technologies have their own pros and cons. The analytical sensitivity of CMA is higher, which can identify smaller gains or losses in genetic material. However, since the total amount of the genetic material remains the same, it cannot identify a balanced balanced translocation. And this was identified by a karyogram in this case. Further, this family was counseled to undergo IVF and a pre-implantation genetic testing to ensure the selection of a healthy embryo and a successful pregnancy. With this, we come on to the topic, that is fetal genetic testing. So chromosomal abnormalities are more common than we generally realize. It's said that 10 to 15% of clinically recognized pregnancies result in miscarriage. And among these, 50% of miscarriages in the early stages of pregnancy are due to abnormalities of chromosomes. And among these abnormalities, 40 to 50% of the abortions are seen, which happen in the first trimester. And 65% of these chromosomal abnormalities are trisomies. 2 to 5% of live births, however, have recognizable chromosomal or genetic abnormalities, of which trisomy 21, 18, and 13 are the most common, or changes in the sex chromosomes. So we all know the normal process where the haploid ovum and the haploid sperm cell fuse to form the diploid zygote with 23 pairs of chromosomes or 46 chromosomes. Occasionally, this does not happen, and the fetus may not develop properly due to a gain or loss of some chromosome. A lot of the time, these conditions are fatal and the fetus dies within the womb, especially in cases of trisomy 16. However, this is always not the case. These genetic abnormalities are not always fatal, but instead they may cause certain syndromes. And these lead to a reduction in the quality of the life of the baby, of the patient, as well as of the parents. So it is always imperative to be able to identify these cases as soon as possible, preferably in the prenatal stage. So most of the screening that happens in the prenatal stage, we detect three trisomies. The most common ones, trisomy 21, which leads to Down syndrome, trisomy 18, that is associated with Edwards syndrome, and trisomy 13. So the selection of this case was done to show that it was not a very elderly female who presented with this trisomy, which is why now we're moving away from the old adage of, just screening elderly pregnant females. Screening should ideally be offered to all, especially since 87% of all live births are to women under 35 years of age, and because 55% of the estimated Down syndrome births occur in women under 35 years of age. So ideally, of course, if we were living in an ideal world, all pregnant women should undergo screening. However, if any of the following risk factors are present, in those cases, it becomes all the more mandatory. So a female with age 35 or older, known family history of birth defects in the family, an enhanced risk shown in another screening test, either biochemical or radiological, a previous child born with a birth defect, or history of insulin-dependent diabetes in the pregnant female. Of course, prenatal tests to detect these trisomies have been conventionally classified into screening tests, which estimate the risk of the trisomies, either high risk, moderate risk, or low risk. And after this, of course, we have the diagnostic or the confirmatory test, which should always follow our screening tests. These obviously include the invasive testing in the form of amniocentesis. So elaborating the tests that we use for prenatal screening. So we have our markers, double marker, quadruple marker. And apart from this, when it comes to fetal genetic testing, we have NIPT or NIPS, that is the non-invasive prenatal screening. That screens for trisomy 21, 18, 13, with a sensitivity of more than 99%, especially in cases of trisomy 21. Work also screens for numerical anomaly in sex chromosomes, numerical anomalies in autosomes, and certain microdeletions. So why NIPS? It remains the most sensitive and specific non-invasive prenatal screening test. It uses NGS technology, of course, to detect cell-free fetal DNA in maternal blood. It screens for trisomy 21, 13, 18 with more than 99% accuracy, and other chromosomal abnormalities with an accuracy of 95 to 97%. A major advantage is that we can start testing starting from the 10th to 11th week of pregnancy. Other than monosomy X, which may show signs of anomalies on USG, there are currently no specific screening modalities for sex chromosome aneuploidies. Invasive procedures such as chorionic villus sampling or amniocentesis, of course, are the only methods to definitely diagnose a chromosomal abnormality in pregnancy. But as we all know, they do carry a small risk of miscarriage. So again, how is it done? Very briefly, because we are, of course, constrained by time. Cell-free DNA is purified from the maternal sample that we obtain. DNA library is prepared and the whole genome is then amplified. The sequencing is performed by NGS technology with 6 to 10 million sequencing reads done, and reads are aligned and analyzed as per the bioinformatics pipeline. These is how we report the results in our NIPS reports. Low risk, which signifies that it is very unlikely that the fetus is affected by aneuploidy of the tested chromosomes. High risk, which means that there is an increased chance that the fetus is affected by aneuploidy of the chromosomes that we've tested. All high-risk cases should be confirmed by an invasive diagnostic test, preferably, of course, by chorionic villus sampling or amniocentesis. Apart from this, we have something known as a failed test or a no-call. This is a result seen in 1% of our test samples, which means that a result could not be definitively produced, whether it is a low risk or a high risk case, most probably due to a low fetal fraction, which happens to be a crucial quality control parameter for interpretation of NIPS results. So a fetal fraction of less than 3.5% often leads to failed tests. And it's also important to remember that a low fetal fraction has often been shown to be associated with aneuploidies. So these two should be followed up. Since we're talking about fetal fraction, these are the factors that lead to an increase or a decrease with the of the fetal fraction. Among these, like I was mentioning in my previous slide, fetal aneuploidy is often associated with a decrease in the fetal fraction. Other variables include maternal rate, which decreases fetal fraction, maternal autoimmune disease, certain drugs such as low molecular weight heparin, maternal age, etc. These are the NIPS screening tests that we offer at Pathkind Labs. So we have NIPS Basic, which offers screening for aneuploidies of chromosomes 13, 18, and 21. NIPS Advanced, where we add in sex chromosomes along with the above three. It's very important to remember that only aneuploidy is reported. We do not disclose the gender. And an IPS Comprehensive, where we screen all 23 pairs of chromosomes. So often there is a question asked as to which test to go for, depending on certain situations in aneuploidy detection. So if the patient comes to you between 12 to 18 weeks of gestation with a screen positive for any of the trisomies, it's always ideal to go for an NIPS. In case of an advanced stage pregnancy, you can obviously go for an NIPS. In case the patient is coming to us for the first time at 23 to 24 weeks of gestation, or she has a quadruple marker screen that is positive for these trisomies, an invasive testing procedure is preferred. If there is any abnormality on the ultrasound, irrespective of the gestational age, it's always advisable to go for amniocentesis or an invasive procedure. If we're getting a POC sample, of course, we go for chromosomal microarray. So how do they hold up? How do the non-invasive prenatal screening hold up against amniocentesis? So what information can we provide? With an IPS, we tell you about the fetal aneuploidy of almost all the autosomes and the sex chromosomes and certain microdeletions. In case of amniocentesis, it depends on the technique that we're using. So karyotyping tells us about the numerical and structural abnormalities of the chromosomes. Microarray can tell you about the aneuploidies as well as the gain or loss at the band level, but like we saw in the case, not balanced translocations. PCR can tell you about the specific gene or single point mutations, and of course, NGS can tell you a lot more. Analytical sensitivity again depends on the method that we're using, post-amniocentesis, whereas it is more than 99% for an IPS. Risk factors associated with an IPS, almost none, but of course, there's a 0.5 to 1% risk of loss of pregnancy or miscarriage following an invasive procedure. So a take-home message for an IPS is, of course, there is a superior accuracy and low false positive rate for an IPS. It has an extremely false positive rate of less than 0.1% and a high positive predictive value for trisomy 21. It is validated in singleton and twin pregnancies of at least 10-week gestational age. We do not detect neural tube defects with an IPS. Twin results reflect the probability that the pregnancy involves at least one affected fetus in case we get a positive screen in case of twin pregnancies. Where should you not use an IPS? It is not validated for use in pregnancies with more than 2 fetus, demised twin, mosaicism, partial chromosome aneuploidy, translocations, maternal aneuploidy, transplant, or malignancy in mother. Very important to remember that it is not a diagnostic test and results should be considered with other clinical criteria. So with this, of course, we have an entire array of solutions for reproductive health for bad obstetric history, starting from when the mother is carrying the fetus to the newborn stage, wherein we offer testing for inborn errors of metabolism, and also going on to post the newborn stage. So, of course, change is the only constant, and there is a changing pace of laboratory diagnostics where we adopt new biomarkers, new technologies, newer diagnostic guidelines and algorithms are always adopted. Since diagnostics is evolving, so are we. And we are Pathkind Labs Private Limited, from the promoters of mankind, strongly believing in Jaat Sahi to Ilaj Sahi. And we offer an entire array of services ranging from the smallest of tests, most basics of biochemistry and hematology tests, going on to the most advanced investigations of molecular diagnostics, cytogenetics, and now even HLA. We are led by these technical experts at our National Reference Lab. And we're very happy to announce the launch of our newsletter, our academic and medical newsletter. Please do visit us at our stall 17. And that's all from me. That's all from us. Thank you for your patience.